So my name is Adrian Wilson. I'm going to be talking to you today about my experience with All-Inside. I'm going to try and keep to time, looking at that clock already. So in our unit we do a lot of new techniques, new ideas are tested on the patients, and I think whenever you're doing that it's really important to follow your patients closely. So we have a big research team and we get a huge amount of support from Arthrex. We have a dedicated physio. We have a dedicated data analyst and someone now running the research. And as a result, we can really keep a very close eye on our patients, which is extremely difficult to do. It's very time-consuming and it's very expensive. So all-inside ACL surgery, everyone in the room is familiar with this concept. The animation that we can see is how we were doing the surgery, making a complete tunnel. And what we've moved to is low-profile buttons, sockets, which are bone-preserving, and we're doing this by using the flip cutter. And by doing this, we can make a socket as opposed to a tunnel. And we move away from the lower left picture, where we're using screws and staples, to these modern cortical fixation devices. So the other main advantage, I would say, is this procedure is soft tissue preserving. So we take a single semitendinosus, and we can use that, and we can leave the gracilis for proprioception and strength and so on. It's an important medial stabilizer. But also, more and more now, we're learning about these new extra-articular procedures, particularly the ALL, and by just using the semi-T for our ACL, we keep our gracilis for these additional procedures if necessary. We usually use autograft, as you're all familiar, a single quadrupled semitendinosus, but in the presence of a small graft, we can combine the gracilis and the semitendinosus to make a larger 8-strand graft link. This is a very clever tool. This is a minimally invasive way of taking a quads tendon, which I think is a very good option for the revision procedure. And this is something I advise you to take a look at on the stands outside. So what about allograft? We do a lot of revision cases. I think this is a huge saving in my practice. We're using one allograft now as opposed to two, and they're approximately £3,000 in the UK, so it saves the hospital a huge amount of money to use just a single allograft. And Arthrex UK, as well as the rest of Europe now, is supplied by these ready-made allografts, which literally come out of a packet, and it takes you a few minutes to prepare yourself an allograft for all-inside ACL or PCL. For the PCL, we use the peroneus longus or tibialis anterior. So we came up with this concept a few years ago. These are two concepts that I'm going to show you in this short video. The first is reinforcement. So here, this is a small pediatric case. This is a very small graft, just 7 millimeters in diameter. And all I'm doing is laying some fiber tape into the middle of the graft, and we called that reinforcement. I think to marry up with Gordon's ideas and the internal brace, probably an easier concept now is to think of it as an internal brace augmentation to the procedure. So into the compression sleeve, we're initially size 7, fairly tight, and then we pull into this second compression sleeve, and what we find is with autografts we can downsize by half a size pretty much every case with autograft. With allografts it's almost as much as 2 sizes. So it's amazing how you can then make a smaller tunnel because you're using a smaller drill or smaller flip cutter for the case. So we've investigated this, and Andrew Amos is just completing a study with Breck Lord, and what we're finding is we get a 20% reduction in this study in terms of downsizing, and we see an 18% re-expansion when we allow the grafts to re-expand. So we're putting it into a tighter fit into the socket, and then we're getting re-expansion, and we hope that we'll be able to show less synovial extravasation and tunnel widening and so on because of this press fit that we can achieve. So what about the technique? We find 70 millimeters the ideal graft length. So we resect the semi-T at 27 centimeters. When we quadruple it, it gives us a 70 millimeter graft. Then we do some very, very simple steps within the procedure to mean that we don't have to do any calculating. So we make a 20 millimeter socket on the femur every time. So that's for every single case. This socket is made to a depth of 20 millimeters, and a fiber stick or tiger stick is passed. We then make the tunnel 30 to 35 millimeters on the tibia, and that gives us our tensioning side of the equation. So we never have to worry about running out of graft. This is a very clever idea that came from Bertrand Sonricote, which is direct visualization of the button. So here we can watch it going through the pilot hole, and then externally we can simply move the scope into the lateral gutter, and we can then look with direct visualization and watch the button externally. So here we have the internal view, and then it's very simple just to move the telescope into the lateral gutter and watch and seek the button under direct vision, which gives you a lot of security as you're leaving the theatre that the button is in the right place. I think... Naughty Jürgen. So, what about some results? So we've been following the cases, and in this series now we have, in my NHS series, 343 cases. The mean age is 33, and the follow-up is out to 5 years for some of these cases. Primary is 295. We get a lot of tertiary referral cases from other centres, so we do a lot of revisions, many as mostly as one stage, but often as a two-stage. And this is the effect of those compression sleeves. So we're able to take the average graft size of approaching 9 millimetres and get that down to just over 8. And I think this really is made a big difference to how we perform the surgery, because we're always making the tunnels or the sockets that little bit smaller. So everyone is followed up in the standard way, and the patients are seen at the regular intervals that we would all see our patients to get their Kuss, Lischheim and Tegner, and the scores are looking very good. So this procedure works. The interesting thing about the GraftLink, because of the biomechanics of the graft itself, all the surgeons that move to GraftLink always say how much tighter and how much more stable their patients feel because of that type of graft. And this is something that we've experienced as well. So we've looked at the range of motion, which has been well preserved, and we've looked at the KT data, and everyone gets a KT assessment, and in the children now we're using the Kira. Obviously we've had some complications. We had no infections for 250 cases, so I thought we were never going to see an infection ever again, and then actually we had 3 on a trot. It must have been something to do with sterilisation. In a period of about 6 weeks, 3 infections that were deep, and we've had none since. So I don't know whether this procedure is helping me to... I mean, this is not an operation that often is problematic with infection, but we found a low infection rate and also serious complications very low. There are many advantages to this particular surgical procedure. We get a lot of paediatric referrals, and we use an all-epiphyseal technique wherever possible, and in fact we use parental donor tissue now in the small Tanner 1 and Tanner 2 children who are going for a formal reconstruction. And it's very easy to use the flip cutter, particularly with the paediatric guides, to stay below the physis. What about additional procedures? So again, if you're doing complicated surgery such as an ACL and a uni, I think this lends itself very well and makes this procedure very, very much more straightforward. In the revision case, you can often completely ignore the existing hardware. You can position the flip cutter wherever you want, and you can navigate a new socket very easily without even thinking about the existing hardware, which makes these cases much more straightforward. This is a grenade that's gone off on the right-hand side. This is where we were as patients were being referred in and having one go after another, and it just makes the point that the hardware is an issue. And with these low-profile buttons now, we have this elegant way of carrying out this complex surgery. So what about using the concepts of All-Inside in the paediatric cases? And I just want to finish with just a few minutes on repair. Because this is an innovation meeting. So this is a little 5-year-old. I leave the pictures up just to show the physes are obviously open, a skeletally immature 5-year-old child with a complete rupture of the ACL, and you can see that from the images shown. So we do Gordon's technique, we reapproximate, we put the fibre tape in, and at 3 months I always take the hardware out in the children. We have a look, and actually we see a well-healed graft, and normal appearances with no synovitis. So this girl's now out to 2 years. She's surfing, she has a normal knee, she has no subjective symptoms, and we use the Kira, and there's less than 2 millimetres side-to-side difference. We were asked by Kista to use a KT, because we're publishing this next month, and you can see the KT doesn't work too well because it's too big, but we found with the Kira, actually, we got some very nice objective scores. On a 6-year-old, same story. So again, a very small Tanner 1 child. We did the all-epiphyseal technique, and again, when we see this child, and importantly, we can do this through 2.4 millimetre tunnels. So we're not burning any bridges with these children. We see this child at a year, and again, full range of motion. The only reason why his Tegner is his mother won't let him play football yet, although he's desperate to get back. Again, the KT far too big. So we use this Kira device, which has been validated, and we have less than 2 millimetre side-to-side difference. So we've been following up these small children and looking at their scores. We've had no failures. and I think this is a very good technique for the skeletally immature in terms of repair. So just to summarise about All-Inside ACL, it's soft tissue and bone preserving. Use a single hamstring. We can preserve the other hamstring for proprioception and strength, but also use it for additional procedures. I think this should be the gold standard in children personally. It's very beneficial in these complex multi-ligament cases, and in our series we have very good results now out to 5 years with less than 5% failure and a low complication rate. And this is supported by other series which are now out there, and we hope very much.